And number 5.
Here we go
again. Thank you very much, guys, for coming back. This week we thought we'd run through a case. So we're going to divide it in two parts because it's such a big case. There's so much to talk about. This is a case that John, you treated recently. So we'll walk through it with you guys, and we've divided it up. So let's talk about all the aspects.
Yeah, so she, a lovely lady actually, presented to me with a bit of pain and discomfort on biting from this upper left 6. Previously had quite a long protracted pain history, very sensitive to cold, that kind of classic pain on release of biting that they talk about with cracked cusp. And we can see up on the graphic here that we've got that crack in the marginal ridge here. So she had that very difficult diagnostic pathway where cracked tooth, does it need to be root treated? Can we wait? Can we not? Anyway, she then got an acute episode of pain from this tooth, developed apical periodontitis, real pain on biting. And when she presented to me, it was more of a dull ache than anything. So we're more in the kind of chronic phase of things here, which is often the way when in our kind of referral practice, isn't it?
Yeah, for sure. And in your case, I know we've got the two-dimensional picture here, but on a sort of a consultation appointment, which is how we operate, what tests do you run on this tooth?
Just regular stuff. So we'll do sensitivity testing. So we use EndoFrost, one of the refrigerant sprays. Hold it on the buccal aspect of the tooth, and we just sit and wait for 10 seconds. We're not getting a response, so it's not just put it on and let it go and that's a non-vital tooth, but we really give it opportunity to fire a nerve impulse if it can. The other things we'll do a simple percussion testing. I tend to do that with my fingers or biting on a cotton wool roll. I tend not to hit teeth with a mirror because you can make anything hurt if you hit it hard enough. So it's quite a crude test for me, that tapping things with a mirror. And lateral pressure I think is really quite critical as well. Other things, very, very simple. You're trying to piece together a bit of a pain history. So you're looking at what the tooth has got. Okay, you're listening to the patient, you're looking and trying to marry up the presenting complaint with what's in front of you, both clinically and then on the kind of special investigations, the imaging, if you like. And I mean, we can see here on this, you've got an occlusal amalgam restoration, and so often we see this. That had been there 35 years, so a wonderfully successful restoration. But we've got a very calcified canal system, so it's a challenging tooth. Do you find that with cracked teeth, you tend to see much more calcific change within the pulp chamber?
Yeah, I was going to ask you that. A lot more with anything that has a stained craze line, like in this case, or a crack. I find that pulp chambers tend to reduce, pulp systems tend to reduce, and probably because it's been a chronic progress. Small crack, small filling, just starting a change, and you get that deposition of dentine and calcification. You often get pulp stones with such teeth, actually. So they tend to be a bit tricky. And I know we've got a 2D image. I know we've got it on the screen, and it's even on our screen. It's okay, but it's not mega conclusive. So I know you and I are big fans of 3D images. Do you scan everything that walks through the door then, in terms of CBCT?
No, we don't scan everything that walks through the door, but we've got a high propensity to use cone beam for sure. I think the more we have started using it, the more we see the value in it. And if we look at it here, we certainly can see the diagnostic benefit of it. So diagnostic benefit is one thing, and then treatment planning benefit is another. And often I think that kind of gets missed in the conversation. You have to be sensible about it because it is radiation dose. We're not scanning the patient as they're walking up the stairs, but where we see there is added value, and that is in the majority of teeth that we treat, then we will be taking a 3D image. And have a look at this, for example.
Walk me through. I know you have the scan, and we have the scan here. So walk me through what you're looking from a diagnostic and treatment perspective. Because we hear it a lot. Why should I scan? Why should I not scan? What's the point of me scanning? I can find the canals. So what do you gain from having this 3D picture, apart from patient information and educational?
I think for me, confirmation of diagnostics is really is important, and we know from
Even I can see that radiolucency.
Yeah, exactly. And we know from the work Shannon Patel's group at King's. I was very fortunate to train under Shannon, and we know that the diagnostics of seeing a lesion in inverted commas, a radiolucency, the sensitivity is much higher on cone beam than it is on a 2D image. On a case like this, you then start seeing things like the sinus floor thickening. You can see how it's bumped here. On this is a palatal root on the sort of right side of the screen, just by Luca, and it emphasises that the chronic apical periodontitis can have impact on the surrounding structures, and I like to know that as well, because we're looking at the sinus here, but how often are you seeing radiolucencies in close approximation, lower sevens next to the ID nerve, for example? I like to be able to bring my patient much better into a kind of a risk analysis of the treatment, particularly in the UK where we are. It's we're quite a litigious society, and I just like to have all the information so I can stand with the patient in front of the TV screen and we'll talk through it together. Yeah, this is your tooth, this is what I'm seeing, these are the risks. I think it's worth it or it's not worth it, and if it is worth it, X, Y, and Z are potential sort of knock-on effects. Yeah. So for me, diagnostics is really key. How about for yourself?
Yeah, for sure. And I think this patient also had some sinus issues, from what I remember. So I think this is what we've found a lot more. We know there's a relationship between maxillary teeth and sinuses, but the more you see these CT scans, the more you start piecing the symptoms together. And there's a plug for the podcast Endo Voices from one of our counterparts in the US, Marcus Johnson. So it's an AAE podcast, and it's fantastic. Lots of different topics, and they cover sinusitis related to odontogenic origin, and you can start putting things together. And I think you help a patient much further, because if you were to just treat a sinus problem or a tooth without marrying the two, you would be selling yourself short. So this, I think, has been quite a big revolution, and certainly for confirmation diagnostics. But I think for treatment planning, risk assessment, and treatment planning, you've got a nice animation. Walk me through this.
Yeah. So this is just a screen recording of what I do, basically, and what I'm trying to work out here is where my access point is for my access cavity. So one of the other benefits we see from cone beam, and we noticed that this was quite a calcific tooth. So you have a receded pulp chamber, and you can see here on the axial slice. So we're going up and down the tree trunk slices of the tooth as I describe it to the patient.
You can just see the pulp stone there coming up now, isn't it?
Yeah.
In the middle.
And it allows us to line everything up. So I'm getting a bit of a flavour here, what canals we've got. Am I likely to find an MB1? Is there an MB2 in here as well? We're then lining up with the pulp chamber to create the ideal access line and point of access, so that we're going to minimally remove tooth structure in the process. So diagnostics is one thing, and yes, we could get in there and find out when we're in there. I'd quite like to know what's in there before I go in. That's just my philosophy in dentine preservation.
This one as well, you've got an MB root. If you see that it's a long one, you know how much you can brush and find more about it. If you have a very small cylinder-like mesobuccal root, you'd be probably digging a little bit less in that MB palatal direction. I find that I just go searching for things a lot less. Yeah. Yes, and I think that line on the scan really shows you that it gives a picture of which way your burr is going to enter, especially with teeth that are tilted. Yeah. Lower molars are fantastically helpful, because they tend to be lingually tilted.
This is good, because we know with this, that line was penetrating straight out from where the restoration is. So let's just take the filling out. We've got a crack here, so we know that the marginal ridge is no longer intact. So if you didn't have a crack on either side, on the mesial and distal marginal ridges, you'd probably be restoring this with just an occlusal composite. Yeah. Because that enamel ring, the peripheral rim, is intact and sound, the rigidity is retained. But what we tend to find with these cracked teeth is they have flex in the system. So what we've got, again, just by Luca, is the depth grooves that we cut to make sure that we do the occlusal reduction sufficiently. So this is done with a 020 burr to make sure I do a 2mm reduction, and that's broadly what we're going to overlay afterwards with. Really simple. And it's quite interesting when you look at it, because you're still working out at this stage, aren't you, whether the crack is treatable or not treatable. And if we look at the image just above my head, you'll see on the mesial aspect there's almost like a little decalcified area. Occlusal effect caries, and there's that wonderful paper by Graham Milicic that talks about this effect, and it's a tremendous paper to have a look at if you do have a spare 20 minutes to sit down. It's really kind of it's good thinking.
Yes.
For me, cracks are still the hardest thing.
Yeah, I have a low tolerance, I think, for them. We base it on location and depth of them. So if they mirror each other mesially and distally, or buccal and lingually, if they go down into the pulp chamber across the floor, that's a no-no. So if it runs across the pulp floor because the tooth is trying to flex, if you have stained cracks that mirror each other, again, that's quite low prognosis. So those are all little things that we look at. And we also base it on alveolar bone height. So we had the CBCT scan, which is incredibly helpful to see whether there are any small gaps in the bone, or that's what you can do with periodontal probing with a fine UNC 15. So that's any probing depth for us is really almost a non-starter in terms of treatment, whereas this one had fantastic bone levels all around, good periodontal health, so really a goer, sure. Yeah,
and I think also you need to come back and think about the bigger context that's in front of you, because so often we operate with the endodontist hat on, and we're very fortunate in the practice. We work alongside restorative dentists that are highly skilled in proso, understand occlusion far better than we ever could, and parafunction is such an important thing to look at. So the crack is just a symptom of something going on, and it's very easy to get drawn into that single tooth approach to things. But actually, this lady, maybe she had some worn canines, whatever, she's lost the canine guidance, she needs to have a look at it, maybe she's got nocturnal parafunction, whatever it may be. So these are the sorts of cases we see this, and actually we're very fortunate in the practice here that we will collaborate with people that know more about it than we do, and we're not afraid to say that, because endo is our thing, and occlusion, restorative dentistry is very much theirs. And we then kick off with this tooth, because the cracks were sort of what I described, they went to the pulp chamber but not across the floor. So they're significant enough to cause a problem, but not significant enough that they will be a long-term problem from a functional, structural perspective. So we start off in this case, I want to try and keep tissue, because why would I take a ton away when I don't need to?
So what system are you using here?
So this is TruNatomy again. This is using the modifier, as you like to call it, the Shorty. And it's great. So really simple to get in, nice and short. And we spoke about this in the hands-on last time. So we're looking at it now in clinical environment. Little up-down movements, and you're just opening the top of it. What are the benefits for you of this, if you like, orifice enlargement, coronal shaping?
I think the good things about this, we like this system for primary treatment, as you said, to keep as much dentin as we need. It's a cracked tooth, so we don't need to remove any more dentin. The advantage of the Shorties, or the purple orifice modifier, is that it's short, so you can get to posterior teeth quite easily. It's heat treated, so you can pre-bend it. That's all I need. That's lovely.
Absolutely, and then we can get the chance to move on to the glide path. And
we're getting a bit old school with this one.
I love these. These are one of my favourite files that I use in endo. This is the path file from Dentsply Sirona, and they've got a 13, a 17 and a 19, so it's not quite, you expect it to be 10, 15 and 20, but it's not quite. They're 2% taper and regular niti, and they just bridge the gap between a size 10 and the glide path file, and it's that small step in a regular niti, which is very cutting efficient, it helps you get down calcified canals brilliantly.
Why do you need to bridge between 10 and 15? What's so difficult? Because all the issues we see are on a file on a size 15. What's the problem there?
It's just a big jump. It's simple maths really. You go from a size 10, 0.1 mils to a size 15, 0.15 mils, 50% increase. There is no other point in endo where you make that same sort of leap, if you like, in terms of diameter, and that's where this bridges the gap. And I think that kind of sums it up very nicely. And we are only going to use the 013 in this case, the purple. So I typically will use the purple path file in a calcified tooth like this, and then we'll follow it with the proprietary glide path file, the TruNatomy glider. The big challenge for me with this tooth and with this type of instrument is that it's regular night-eye, so you can't bend it.
Yeah.
So access has to be forgiving to some degree. Yeah. Whereas the glider is a slightly different beast in the fact that you've got a controlled memory. So this is the TruNatomy glider. And I think we can see here that it doesn't go the easiest, it's not unimpeded. So that we can just put that little bend on it. You're just using fingers, careful not to stab yourself.
And the microscope?
Yeah. Turn it so it's facing the right way. You've got a pre-bend. It's lovely shot this, and you can see now that will just go in nice and easy. And that's why I probably speak on your behalf, do I? Control memory, glide path files, the way to go?
Yeah, for sure. For nowadays it is. This is contemporary endo, going a little bit of a old school nod to the early noughties, and then back to contemporary endodontics. We're sort of putting in these two systems ever so slightly, but that's the only mishmash that we do. We keep it simple, but heat treated is the way forward for us in terms of instrumentation. So you've done your glide path, and what other files are out there that you would know as glide paths? We'll cover that in more detail, I think, next time, but what other files would you throw in the mix here?
What, that I would use or that exist?
That exist really.
I think probably my next choice would be the Wave 1 Gold glider. Again, controlled memory, so you can pre-bend. I really like it. It's a really nice, safe glide path file. Otherwise, other things that exist, you've got the HighFlex EDM, the 1503.
Coltine one,
It's very nice. You've got the 1G from, again, Coltine Micromega. It's Micromega, but Coltine Micromega. And then you're looking at the Pro Glider, which obviously is a Martin-Sittick wire, an M wire, and then the newer Slider, which is part of the Pro Taper Ultimate sequence. But the drawback of both of those, the Pro Glider and the Slider, is that it's not bendable. And actually, if you want to be doing more dentine preservation stuff, it's quite a critical part of the property makeup of a file.
It's about access, it's about ease. It is very resistant and flexible, but you can't pre-bend it. And if you're working on upper 6, MB1, MB2, let me know tomorrow what you think of things that you can't pre-bend. not in his day at the office.
Make life easy, for sure.
And once we've got the glides, we finish.
Simple as that. And in this case, obviously we've got 4 canals, so the MB1, MB2, DB, we're all finished using the Prime. So as you remember, this is a 26 at the tip, 4% variable taper. Again, see the little pre-curve? Just make life easy.
Very nice.
And again, it just ensures that during the whole shaping process, you're not over-enlarging that coronal aspect. You just don't need to when you just use the technology that's available, really. This was actually slightly bigger in the palatal, so we just finessed it with this.
I think that's what you were mentioning in our previous, when we did the hands-on with the TruNatomy in the podcast number 4, we just talk about the different sizes and why you would go up in terms of finessing the apex. I think that's the beauty of it, is that you can just change the size according to whatever you feel the file, the technology is doing.
And it's just that simple up-down movement. Simple up-down movement. There's no extensive brushing. Again, brushing removes dentine in the coronal area, and we've already done enough of that with the modifier that we've got. So, it's a really yeah, it's a simple overview, and we were asked, by some friends and colleagues again on social channels to have a look at workflow, and hopefully you can see there, running through the diagnostics into the kind of planning of access cavity, the cusp reduction, and then the instrumentation sequence. It's quite, we're pretty formulaic, aren't we, with what we do?
Yeah, absolutely. Repetition.
Yeah, that's where you want to get to boring repetition. That's when you know you've got the workflow nailed.
What we'll do is we've covered the diagnostic, the preparation, so the restorability assessment, cusps down, and the preparation. We'll stop here, and what we'll do in the next episode, we'll cover the irrigation, the obturation, and the final restorative work for this tooth. So just hold that suspense for a little bit longer.
Cool.
Thank you for joining us, guys. Bye.
Cheers.